Hey everyone, and welcome to This Explainer. Today, we're doing something a little different. We are taking a highly focused, purely medical look at pregnancy loss and abortion. By stripping away all the external noise and debates, we can really get down to understanding the biology, the terminology, and the actual healthcare protocols that medical professionals use every single day.
Here is our clinical roadmap for today. We'll start by defining pregnancy loss, move into spontaneous abortion, cover the types of spontaneous abortion, explain induced abortion, and finally wrap up with care and management. Let's dive right in. Section 1, Defining Pregnancy Loss, the Medical Baseline. Let's get our foundational definitions squared away so we're all on the exact same clinical page. Okay, so the absolute crucial point here is understanding the stark medical definition of viability. Now, while the general public often uses the word abortion to mean one very specific thing, in a clinical setting, it literally just means the termination or loss of a pregnancy before the fetus is viable outside the uterus. Depending on the country and specific medical guidelines, this is typically defined as occurring before 20 to 24 weeks of gestation or when the fetus weighs less than 500 grams. Under this massive medical umbrella, we basically have two primary branches. First, there's spontaneous abortion, which is a natural loss without any deliberate intervention. And then there's induced abortion, which is the intentional termination of a pregnancy by medical or surgical means. Understanding this distinction is absolutely key to all the clinical protocols we're going to talk about next. Moving on to Section 2, spontaneous abortion or natural pregnancy loss. In everyday language, we almost always just call this a miscarriage. Now, you might be surprised to learn that roughly 10 to 20% of all clinically recognized pregnancies end this way. That makes it the most common type of pregnancy loss, hands down. But here is a truly striking medical fact for you. The actual rate is likely much, much higher simply because so many early losses happen before pregnancy is even recognized by the patient. So why does this happen? Well, clinicians group the incredibly complex underlying causes of miscarriages into 4 distinct buckets. The most common cause in the first trimester is fetal, specifically chromosomal abnormalities or genetic defects where the biology just simply cannot sustain development. Then we have maternal causes like uncontrolled diabetes, thyroid disease, or autoimmune issues. Third is placental causes, which usually involve abnormal implantation. And finally, environmental factors, things like smoking, alcohol, or physical trauma. It's a massive, complex interplay of biology, not just a single trigger. Section 3, Types of Spontaneous Abortion and Their Clinical Classifications. A miscarriage isn't just one single event, so let's look at how doctors classify the different phases. To synthesize a massive amount of symptom data, medical and nursing education uses a really clever mnemonic, TIC-CMSR. That stands for threatened, inevitable, complete, incomplete, missed, septic, and recurrent. It's a brilliant little tool that helps professionals instantly identify the varied presentations of pregnancy loss. This is where we turn a mountain of symptom data into digestible, actionable facts. Clinicians use specific factors like cervix dilation, bleeding, tissue passage, and fetal heartbeat to diagnose the exact type of loss. For instance, in a threatened abortion, the cervix remains closed and a fetal heartbeat is usually still present, meaning the pregnancy might actually continue normally. Compare that to an inevitable or incomplete abortion, where the cervix is open and bleeding is heavy. Then there's a missed abortion, which is fascinating from a diagnostic perspective. The pregnancy symptoms might just totally disappear. The cervix stays closed, and there's very little bleeding, but an ultrasound reveals no fetal heartbeat. And septic? Well, that indicates a highly dangerous complication involving infection. By checking these 4 clinical columns, doctors know exactly which care protocol to trigger. All right, Section 4, Induced Abortion Explained. Now that we understand spontaneous events, let's explore intentional medical care. When performed by trained providers, induced abortion is incredibly safe. It generally breaks down into 2 main clinical pathways, medical and surgical. A medical abortion is usually done early in pregnancy using specific prescribed medications. A surgical abortion involves clinical procedures, usually something called vacuum aspiration in early pregnancy, where tissue is removed with gentle suction, or dilation and evacuation, commonly known as a D&E, which is utilized later in pregnancy when medically indicated. Let's look at the precise 1-2 punch of the medication mechanism for medical abortions, because the biology here is super interesting. Step 1, mifepristone. This blocks progesterone, which is the hormone absolutely crucial for a pregnancy to progress. Without it, progression stops in its tracks. Step 2 is misoprostol. This medication induces uterine contractions, effectively mimicking a natural miscarriage to expel the pregnancy tissue. It is a highly effective, sequential medical process that avoids surgery entirely, though it certainly can cause side effects like cramping, nausea, and fever. Now, it's really important to note that the specific reasons and legal indications for an induced abortion vary wildly by country and local law. But from a strictly clinical reporting standpoint, the indications medical professionals encounter usually include situations where the pregnancy endangers the patient's life or health, cases of serious fetal anomalies, instances of sexual assault, or simply a patient's request within the bounds of whatever their local legal framework allows. The medical provider's role at the end of the day is to deliver safe, effective care within those established parameters. Finally, Section 5, Care and Management. Let's talk about the clinical protocols that keep patients safe. Whether a pregnancy loss is spontaneous or induced, patient safety is absolutely the top priority. Healthcare providers have to actively monitor for specific immediate complications and keep an eye out for rare late ones. Immediately following an abortion or a miscarriage, clinicians are on high alert for hemorrhage, any signs of infection, or an incomplete passing of tissue. Late complications are generally quite rare, especially after safe, uncomplicated procedures, but they can include things like intrauterine adhesions. And we cannot skip over this. Psychological distress is a formally recognized complication. It really highlights why holistic, compassionate healthcare is so incredibly critical in these situations. Think of the care process as a strict timeline with rigid nursing management phases. Before any procedure, it's all about obtaining medical history, securing informed consent, and crucially, providing real emotional support. During care, the focus shifts heavily to physiological stability, so monitoring bleeding, managing pain, and strictly maintaining aseptic techniques so we prevent infection. Aftercare, that's all about education. It's making sure the patient knows the exact warning signs of infection, administering any follow-up medications, and arranging future checkups to ensure everything is healing properly. While it's definitely not always possible, providers do recommend a few actionable preventative steps for spontaneous abortion to help optimize maternal health. Because fetal chromosomal abnormalities are largely unpreventable, doctors have to focus on those maternal and environmental buckets we talked about earlier. So controlling chronic conditions like diabetes or thyroid disease, seeking regular antenatal care, maintaining solid nutrition, and treating any infections promptly, doing all of this gives a developing pregnancy the absolute safest possible biological environment. I want to leave you with this final thought to ponder. How does understanding the factual, purely clinical realities of pregnancy loss change the way we approach comprehensive maternal health care? When we strip away all the outside noise and just understand the biology and the strict safety protocols, we replace confusion with clarity. Thanks so much for joining me today. Keep asking great questions, and I'll catch you in the next explainer.